Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. Welcome to Plantar Plate Imaging. This is part 5. We'll be taking a look at plantar plate case pathology, taking a look at different cases. Thanks for your time and attention. My name is Dr. Marlena Jabara, and I'm a board-certified American radiologist specializing in podiatric radiology. Looking at anatomic considerations of a classic crossover toe deformity, this is the situation we're trying to prevent. We're looking at second metatarsal phalangeal tears, creating a situation where you have a rotational malalignment where the second toe can cross over to the first. Generally, this is on the lateral aspect of the plantar plate and can create a situation where we have ulcers and increased pressure. And that can be devastating when we consider the effect of our patient population who is afflicted with diabetes. So by accurately diagnosing plantar plate tears at an earlier stage, we may be able to impact forefoot biomechanics. Let's take a look. Here are some plantar plate case examples for your review. So let's take a look at this case. I'm a female with forefoot pain, 35 years old. When I'm first looking at the case, first I try to get a sense of the biomechanics. I try to understand the forefoot parabola and the convergence of the second metatarsal, usually with the hallux. In this case, I notice that the patient has a bunion, cystic change, mild surrounding stress-related edema. I can appreciate the degenerative change along the tibial sesamoid with the helical complex. And I try to understand whether or not there's a medial crossover occurring. That would be more likely for me to understand or predict whether or not there would be a plantar plate tear. And in this case, we can see that the distal phalanx turns medially, and we have this medial crossover, this mild medial crossover where the skin between the first and second are compressed. And we get a sense here of this phenomenon where the rotation of the hallux and the second metatarsal is putting it in closer proximity. Additionally, I'll take a look at the forefoot parabola in general because I'd like to understand if this patient has neuropathic change or what is the degree of pressure. And in this case, this parabola has this appearance of this type of forefoot supination mechanic. And I'd predict that this patient had some kind of pes cavus. So moving on from that point, looking at the plantar plate complex, understanding the increased pericapsular soft tissue thickening that I see here. Secondary signs such as a pseudoneuroma that we discussed are where we're going to assess this region of the interdigital nerve. This is the nerve. This is perineural fibrosis. And it has been found for you to guide you to assessing whether or not that this is a lesion associated with the plantar plate pathology, that you would construct and bisect a line. And if a portion of the neuroma or pseudoneuroma lies closer to the plantar plate issue, this is considered perineural fibrosis, and the etiology of this neuroma is based on that plantar plate instability. Looking at the anatomy that we talked about earlier, when we're thinking about the plantar plate complex, dissecting away the flexor tendon and the tenosynovitis that we see here. Moving towards the joint line, we understand the accessory collateral ligament to the proper collateral ligament here. And moving distally, in this case, we can see that there's a rent between where the plantar plate, which is the deeper 2 millimeter band, attaches to the accessory collateral ligament. Let's corroborate that on sagittal imaging so we can understand where we are at the metatarsal proximal attachment of the accessory collateral ligament. The plantar plate in this case being this band here. When we're moving over to the relatively more normal side, more the fibular side, looking at the plantar plate here, we can see that there's a gap in the region of the recess, which is rather sizable at 2.8. I usually allow for no greater than a 2 millimeter recess, usually on the order of 1 millimeter or less. when we look at another articulation to get an internal sense of reference. There's even some increased signal at this central region of plantar plate, but you can see that there's no actual fluid gap. When we compare that to the area of interest, we can see the much higher signal denoting synovitis and this 2.8 millimeter plantar plate to metatarsal head gap. Other secondary signs we can see here, proximal phalangeal edema. And when we look at this region here and corroborate that with the transaxial images, we can see that there's a rent, a partial tear here at the plantar plate distal attachment on the proximal phalanx, and we can see that here. In addition, we have a joint effusion, intermetatarsal bursitis, and mild flexor tendinosis. So altogether, I would term this out as a partial tear of the distal tibial-sided plantar plate and accessory collateral ligament involving approximately 50% with both transverse and longitudinal component. The longitudinal component can be difficult to see, but in this case, you can appreciate the length of this tear, that there is a tear extending in the sagittal plane. It's harder to see on the coronal images, but you can appreciate that in this region here. And that is a second MTP plantar plate tear, partial tear, high grade with proximal phalangeal stress-related edema and pseudoneuroma. Plantar plate tears are an increasingly recognized cause of metatarsalgia, and ultrasound evaluation is very useful in the longitudinal plane. We found that lesser MTP joint plantar plate tears are most common at the second MTP joint, and they tend to involve the lateral distal plate insertion. They can tear transverse and longitudinally, and it's variable depending on the biomechanics. The most common ultrasound appearance of a plantar plate tear will be a discrete hypoechoic defect in the plate substance. You can have thinning, flattening, and even non-visualization of the plantar plate, which may represent an extensive or chronic tear. We can see the typical secondary findings as well with pericapsular fibrosis and assess for the presence of pseudoneuromas and plantar plate distance. In this example here, looking at the second MTP plantar plate, what we can appreciate in the anatomy is the echogenic layer of the metatarsal head cortex. This is some of the hyaline cartilage. We have the plantar plate itself, which is about 2 millimeters in thickness and about 2 centimeters in length. We can see its attachment on the proximal phalangeal base, and we can see a partial tear at the superficial distal aspect with a hypoechoic region leading to the plantar soft tissue. So in this case, we can see that there's a partial tear of the superficial attachment of the plantar plate. It involves approximately 50% of the attachment if you drop a line here and then consider that there's about 50%. We can see some more hypoechoic regions closer to the midline, and then the tear resolves as we pass the midline here. As we perform the Lachman's test, we can see the excursion of the proximal phalanx relative to the metatarsal head, and we would have had a measurement of the metatarsal head denoting this is approximately 50% or greater in excursion with a partial tear and swelling extending to the superficial aspect of the plantar plate. And this would be reported as a high-grade partial tear of the plantar plate with greater than 50% head subluxation consistent with MTP joint instability. Looking at the region of the sesamoid complex, we can appreciate there's a sesamoidal rotation towards the first interspace. When we were born, we had helical sesamoidal facets, and we can see that this sesamoid is no longer articulating in its helical articulation, but rather moving towards the cristae, where there is some stress-related edema. So we can appreciate the hallux valgus deformity, the extensor tendon, some of the sprain of the sagittal band, the region of the bunion, the collateral ligament thickening, and the rotation of the sesamoid complex towards that first interspace. The altered biomechanics occurring at the second with an attempt towards a medial crossover, where we have a high-grade partial tear of the plantar plate at its attachment to the accessory collateral ligament. I term this out on the tibial side as opposed to the fibular side to help the surgeon identify where we are looking. We can see that plantar plate. We're going to look again at the collateral ligament complex here and see the proper and again the tear of the accessory. Further things that we can see on this examination, intermetatarsal bursitis at the second interspace, and we can use our transaxial T2 or even T1 weighted images to get a sense of the neuroma that would live here, which you can see here, this Y-shaped structure that is measuring from here to here and from here to here. This is your neuroma. And again, we can even see that in the coronal plane where we can appreciate neuromas quite nicely on T1 weighted images, where we can appreciate the enlargement of the interdigital nerve seen here and the length of the interdigital nerve seen here. And we'd measure that. And if it's greater than 3 millimeters, that would be considered a functional neuroma. Now, we talk about an extra wrinkle in plantar plate imaging called the pseudoneuroma, and that's when you have the situation where you can drop a bisection of the intermetatarsal bursa and the neuroma lies on one or another side closer to the plantar plate complex. As seen here, we have this extension of the neuroma towards the second plantar plate in a situation that would be termed a pseudoneuroma. So when the neuroma lies closer to one metatarsal or another, that's given the term pseudoneuroma and is felt to represent greater pericapsular fibrosis and inflammation secondary to instability of the plantar plate complex. Are you ready to take your podiatric imaging skills to new heights? Check us out at RadPodSquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.